There's one question which I'm frequently being asked, and this is, what can I do in case of bleedings? Well, there are a number of ways how you can control these bleedings. So controlling intraoperative bleedings actually already starts preoperatively, for example, with the patient positioning. Especially obese patients may have a much higher intra-abdominal pressure, and it is therefore very important that you already check the positioning of your patient before you start the surgery and make sure that the abdomen of the patient is free and is not compressed. If you have bleedings such as this one that you can see on the video from soft tissues that you can see, that you can locate, these are easy to control. You simply go there with a bipolar, you apply some short electric impulses, and that should do the job. Sometimes, however, bleedings can be a little bit more nasty when they actually come from behind the working sleeve, and then the bleeding starts coming in from behind and around the working sleeve inside. In those cases, you may have to search for the bleeding by rotating the working sleeve and then start looking for the bleeding in the soft tissues of the paraspinal structures. Working endoscopically will actually give you a different view, a real micro view on the anatomy. And here you will frequently see that there is one small vessel right by the cranial lamina, running over the cranial lamina, which may be causing bleedings. Usually, this can also be controlled easily. Just go there with a bipolar. Again, apply some short electric impulses with your bipolar. And again, that should do the job. Bleedings from epidural vessels are usually also fairly easy to control. In the majority of cases, you pretty much know the area where the bleeding is coming from. And then you can apply some short electric impulses, again, in this area. In case the entire screen is red, however, then it may help you if you temporarily increase the flow on your endoscopic irrigation system. This will be done by increasing it for 20 seconds, and after that, your endoscopic system will go back to your standard settings. And what you can also do is temporarily you can reduce the outflow by putting on this black cap on the top of the endoscope. Please remember, we are working with an open system. So you don't have to be afraid that this is dangerous for your patient. There's always enough flow out. It just increases the pressure in the spinal canal slightly, but please remember that the veins is a low pressure system, and this will already be enough to control your bleedings and to slow down your bleedings in the majority of cases. When you face bleedings from the cancellous bone, these may be more challenging to treat at times. As a first step, I recommend that you simply go there again with a bipolar, and this helps you in many cases. Just in case if this doesn't work, then you may also stop those bleedings by going to that exact location with a high-speed burr, and that should also get the bleeding under control. And if all of these measures don't work, then you may also go to the site of bleeding directly, for example, with a dissector, and then you simply need to place the dissector on the bleeding, and then you need some patience, and you simply need to wait for a while, and then hopefully again, this should do the job and stop the bleeding. Then what you may also do is you may go there to the site of bleeding, and you may also check other vital parameters if those are under control. For example, you may check the blood pressure. You may check if the blood pressure is within an acceptable range. You have to check if the pressure with which the patient is being ventilated, maybe that can be reduced for a while if acceptable by your anesthetist colleagues. If you do multi-level surgeries, also 2 or 3 level decompressions, for example, then I recommend that at the end of your last decompressed level, you go back to the previous levels. Be careful when doing so, because when reinserting your endoscope into the spinal canal, your spinal canal is now open. So make sure that you start laterally on the bone of the facet joint and then slowly work your way back into the spinal canal. You can then check if any relevant hematoma has developed in the meantime, and if it has, then you can remove whatever hematoma is there. The advantage is that in the meantime, some time has passed and any bleedings should have actually stopped by then. And then you go there, you simply remove any kind of hematoma, but maybe try and leave those small coagulations that have formed on the cancellous bone, on the surface of the cancellous bone, because that's actually what we want to stop the bleedings from the bone. So you can leave those intact, but other epidural hematoma you remove and decompress the nerves if there has been any relevant bleeding. In any way, you can see there are many tips and tricks which we pointed out to you, and altogether those should help you to get any kind of bleeding under control.